Welcome to our sonography lecture on Pediatric Abdomen Pathology, Part 3 of 7, GI Tract Pathology for the sonographer. This lecture will cover appendicitis, pyloric stenosis, midgut malrotation, intussusception, Bezoars, mesenteric lymphadenitis, and necrotizing enterocolitis. We're going to begin with a really big one for the pediatric population, and that's appendicitis. In appendicitis, we know to break the word down, we have append referring to the appendix, itis talking about inflammation, so this is inflammation of the appendix. What is the appendix though? It's a small little appendage that hangs off of the cecum. If you recall the parts of the intestines, we start with the duodenum, which moves into the jejunum, and then finally into the ileum, making up the small intestine. The ileum then attaches to the cecum, which is the first part of the large intestine. So that appendix hangs right off of the cecum, right where the ileum and cecum connect. Typically, it's also going to lie anterior to the iliac vessels, and it's almost always found on the right side of the body. We know that most of the bowel peristalsis when we see it under ultrasound. However, the appendix is unique in that it does not peristalse, as it contains air and fecal matter. Regardless of age, the normal appendix should be compressible, has a blind end to it, and measures less than 6 millimeters in the anterior-posterior dimension. So here's an image that we have of where the appendix is located. Remember, we have the duodenum, jejunum, and finally the ileum. The ileum will connect to the cecum here, and that is where we will find the vermiform appendix. Unfortunately, the appendix can take on multiple locations. So we can have a pelvic appendix, which hangs more towards the bladder. We can have a pre-ileal or post-ileal appendix, which hang out either above or behind the ileum. We can have a subcecal position where it hangs below the cecum, or a retrocecal location where it hides behind the cecum. Retrocecal appendices are probably the hardest to image. The easiest are most likely the subcecal, pelvic, and pre-ileal, as they are above the bowel, and then the post-ileal would also be a difficult spot to image as well. What you will learn though as you look for the appendix is that you need to look all the way through the pelvis, all the way around that right lower quadrant, and sometimes even up towards the liver and kidney. Appendicitis comes with very particular signs. The first one is typically going to be umbilical pain, which kind of transitions into right lower quadrant pain. The child will most likely complain of nausea and vomiting. Blood work will probably show an infection, so we will see an increase in white blood cell counts and a fever. One of the most pertinent clinical signs and symptoms of appendicitis, though, is rebound pain at McBurney's point. To find McBurney's point, then, what we want to do is look at where the belly button is, look for where the iliac crest is, and about a third of the way in, you will find McBurney's point. When we talk about rebound pain at McBurney's point, what will happen is the doctor will push down, and it's the releasing of that pressure that causes pain or rebound pain at that point. On ultrasound, then, what we are going to see is a non-compressible, greater than 6 millimeter tubular structure in the right lower quadrant. If we put color on, it's usually going to have increased blood flow because it's infected, so it's kind of angry. It's got that extra blood flow. Anytime there is an infection in the body, the fat around it kind of also gets angry as well, and so we see that turn into hyperechoic fat, more so than it normally is. That can also be known as fat stranding. We might also see appendiculis or fecalis. These are very similar to gallstones, except that we see them within the appendix. These often are going to cause obstruction and inflammation, so if they're there, they are a strong indicator for appendicitis as the root cause. Lastly, if the appendix gets to the point where it ruptures or perforates, we will then start to see free fluid collecting within the pelvis. We might also be able to see the presence of an abscess or a phlegmon. So appendicitis first, it's going to be non-compressible. So as we look through that right lower quadrant, we will see a circular structure with a blind end. We are going to push on it. We're going to put a lot of pressure on it. This is probably going to cause some discomfort to the child, but you need to know if this is compressible. If it is not compressible, most likely appendicitis. Normal bowel is compressible. Appendicitis is not. We're also going to measure in the AP diameter. Quite often we will measure in transverse and in longitudinal just to double check our measurements. This measurement will be greater than 6 millimeters in a positive appendicitis. We're going to put color on and evaluate what the area looks like with that color. When appendicitis is present, it is commonly going to show increased vascularity or hyperemia. The fat surrounding the appendix will be more echogenic. So here's our appendix. This is all fat surrounding it. This is very prominent echogenic fat. We might also see fecalist within. So fecalists are usually going to be brighter areas, kind of like the stones that we see in the gallbladder, and they can cause shadowing behind them. If the appendix ruptures, we need to evaluate for fluid surrounding it. So the fluid typically shows up near the tip of the appendix because that is usually the rupture spot. And what we will see are periappendicular abscesses start to form. The abscesses typically are going to have some fluid within, very thick walls, and surrounding vascularity. Here are some more examples of free fluid within the pelvis. What we can see here is the urinary bladder with free fluid here and off to the side of it, and then bowel also in the area. So let's take a look through this video. This is going to show us a case of appendicitis with abscess formation. So here is the appendix. And this is the abscess towards the tip of the appendix. Again, it's got that fluid in it, thick walls, kind of gnarly looking, and it sits right near the appendix. So once we find the appendix, we want to make sure that we are also evaluating for any abscess formation within the pelvis as well. Now, as a sonographer, you are going to be responsible for evaluating the right lower quadrant. The tricky part about appendix exams is that it is very dependent on your skill as a sonographer. If you don't see it, the radiologist doesn't see it, therefore they can't call it one way or another. Now I would say it's probably pretty hard to actually miss a positive appendicitis, especially when they are in that pelvic or subcecal region. It is a little bit more possible if they are retrocecal, but more often than not, you are going to be able to see that positive appendicitis. What gets tricky is when you don't see a positive appendicitis, but you also can't find the normal appendix, and therefore we can't call it either way. And that child is most likely going to need a CT if the clinical symptoms still point in the direction appendicitis. So as a sonographer, it's going to be important that you have a good protocol to get you through the images that you will need to rule in or rule out appendicitis. Now, the very first thing that you're going to want to do is ask your patient, where does it hurt? Oftentimes with children, they'll kind of just use their hands and they'll just say all over, or they'll point to their belly button, or they'll look at mom or dad, and mom or dad will try to tell you. It's really important that you get the child to use one finger and one finger only to point exactly where it hurts. More often than not, that's exactly where the appendix is. So I ask the patient to point with one finger, one area, and have them point there. If they do kind of rub all over, or if they're giggling or laughing when they come in, there's a good chance this is not going to be a positive appendicitis. Not that kids can't be laughing and in pain, but you just know the look on the face, on the kiddo's face. When they have appendicitis, they don't feel good. But once they point out that one area, you're going to use what's called graded compression. And graded compression means to use pressure and kind of drag that pressure across the abdomen. And you're going to slowly increase that pressure as well, because the idea is that we want to displace the bowel while we are looking for that appendix. So we're going to start in that right lower quadrant, putting pressure in that area, trying to displace the bowel so we can get to the area that the appendix sits. We also want to make sure that we are also evaluating for a McBurney sign. So we are going to press in that right lower quadrant and release. Again, if the patient has pain upon release, that is called rebound tenderness and creates a positive McBurney sign. Once we find the appendix, we want to make sure that we are cine clipping the appendix in both its longitudinal and transverse planes to prove that we have found a blind ending structure. Now, it's not uncommon to find parts of the ileum in the area, and that can look kind of angry, especially if they've got some like IBS or other bowel issues going on, and that can kind of mimic an appendix. But the thing is with that though, it'll never end. Appendix has that blind end, that blunt, rounded end. We need to be able to show that to prove that we have indeed found the appendix. We also want to make sure that we are evaluating the internal contents of the appendix. So are there any fecalus? Is there pus in there? What else is going on within? And then we want to make sure that we are looking around it for any free fluid, enlarged lymph nodes, or abscess. Once the appendix is visualized, there are pictures that we want to make sure that we take. We want to take it in a transverse view. Quite often you'll take multiple pictures, one at the tip, maybe one at midline, one proximal, and then one where it joins up with the cecum. The best picture that shows the transverse image of the appendix should be measured in the AP diameter. Again, over 6 millimeters is typical for positive appendicitis. We're also going to use our color to show if the appendix is hyperemic. And then we want to show longitudinal images of the appendix as well. There are cases where the appendicitis starts in the tip of the appendix and then will slowly progress throughout the entire appendix. So if we show that longitudinal image of the appendix, we can show that maybe there is a normal proximal portion and an inflamed tip. So we can really show the progression of the appendicitis. And then we'll make sure to take extra images surrounding the area to show that we evaluated for free fluid or lymph nodes. And remember too that appendicitis really is a numbers game. The more of them that you do, the more comfortable that you are with them, and the more likely you will be to find them. When I started working at the hospital, we would get asked all the time, can you do a quick appendix check? And all of us are like, well, yeah, we can look. I don't know if I'm going to find anything. And for whatever reason, I always worked the kind of early evening hours. And that's when it seemed like all the kiddos came in. And I ended up getting a lot of them. And I was actually able to find them quite easily. Once you see one positive, you know exactly what you're looking for. Later, I started working at the Children's Hospital, and not only did we have to find positives, but if we couldn't find the positive, then we had to document where the normal appendix was as well. And so you get a little bit better. Those are actually pretty hard to find, but you do get better at finding those as well. So then we can rule out that there is no appendicitis actively going on with the child. Just finding free fluid and lymph nodes doesn't always mean that there is appendicitis. There are some other pathologies that can include those findings and also cause abdominal pain in the right lower quadrant. So to prove appendicitis, you have to find the appendix. You have to see its blind end, more than 6 millimeters in AP, hyperemia, fat stranding, non-compressible. You have to show those when you see it. Moving on to another GI tract pathology that we often see is something called pyloric stenosis. So hypertrophic pyloric stenosis is the thickening of the pyloric muscle. And the pyloric muscle sits in between the antrum of the stomach and the entrance to the duodenum. So the pylorus is kind of responsible for relaxing or contracting to allow stomach contents to pass into the duodenum or to stay within the stomach. So when a patient has hypertrophic pyloric stenosis, the muscles of the pylorus get very, very large. And so now it doesn't matter if they are relaxing or contracting. They're just squeezed super tight shut. And so when there is hypertrophic pyloric stenosis, the contents of the stomach can no longer get into the duodenum. The incidence of pyloric stenosis, it is most common in firstborn males. You're also going to see this in rather young children. That muscle starts to thicken from the day that they are born, and it progressively gets worse and worse and worse to the point that they are projectile vomiting. Usually it's like exactly what they ate. So if they had some breast milk, like a minute later, it's across the room, projectile vomiting. Because the child can't move any of that nutrition into the duodenum to use it for themselves, they start to get very dehydrated and they're going to start to have some weight loss. On clinical examination then, as the doctor is feeling around the abdomen, there's something called the olive sign. And they call it the olive sign because right where this pylorus sits, when the muscle gets thickened, it feels like a little olive in the baby's abdomen. So here's a picture of the stomach. We have the esophagus on the top, the fundus part of the stomach, body, and then the pyloric antrum. So remember, the pylorus sits between the antrum and the duodenum. So this is the muscle here. It's the sphincter that keeps gastric contents in or allows them to flow out into the duodenum. Now in ultrasound, we're going to be looking for a few things. There are a couple different signs that we can look for. We can see the donut sign or the target sign in transverse. We can also see the cervix sign. When the pylorus is thickened, it looks exactly like the cervix on a uterus. And then we're going to look at the measurements that we get of the pylorus itself. First, we're going to look at the walls. What are the muscle walls measuring? If they are measuring greater than 3 millimeters, that is one check mark for pyloric stenosis. In conjunction with that, then, we're going to see what the canal length is. We can see the opening from the antrum to the duodenum. If that measures more than 14 millimeters, then that is another check mark for positive pyloric stenosis. So a great way to remember the measurements of pyloric stenosis and when they are abnormal is to think of the number pi. I can't remember all of it now. It's like 3.1428. It's that never-ending mathematical number, pi, pi. And it has that funny little N sign almost. So pi starts with 3.14. The 3 tells us 3 millimeters or more for the muscle wall is abnormal, 14 millimeters for the canal length. So here are some examples of pyloric stenosis. This is the antrum of the stomach here, sitting medially to the pylorus. The pylorus muscle then, this is the anterior part of the muscle. This is the posterior part of the muscle. And then this is the canal that comes in between. Now the easiest way to find the pylorus is usually to keep your probe in transverse, and you're going to identify where the gallbladder is. And that pylorus is usually right underneath it, just inferior to the gallbladder. Down here we can see how the sonographer measured then. Again, these calipers here represent the length of the canal, and then we also need to measure the thickness of the pylorus muscle. So when we're getting ready to scan a patient who has suspected pyloric stenosis, again, these are typically going to be younger babies, typically going to be males with projectile vomiting. We want to make sure that we use a linear probe to identify the pylorus in the right upper quadrant. Remember to look near the gallbladder and roll the patient around. You might go RLD or LLD. If you go LLD, that kind of flaps the liver onto it, and that might be able to be helpful. Otherwise, you might be able to roll them RLD, and that'll kind of flip the stomach onto it. And if the stomach is still full of contents, that might actually help you locate the pylorus as well. However, if the stomach is overly distended, that can really push the pylorus kind of deep into the body, and that makes it very difficult to see. Sometimes the child is in so much distress that they are just sobbing, crying. That makes it very difficult to see because now they've kind of taken in a lot of air into their stomach. And the other tricky part is that sometimes sonographers aren't 100% sure what they're doing and they see the gastroesophageal junction, and that can easily be mistaken for the pylorus as well. Once you do identify where the pylorus is, though, we want to take pictures in the longitudinal plane, so showing the entire canal. That way we can measure the muscle and the canal. Remember, canal should be 14 millimeters or less, and the normal muscle should be 3 millimeters or less. So that's 3.14 coming back in. We also then want to show in the transverse view an image that demonstrates that target or donut sign. We can also take measurements of the muscle in this view as well. Lastly, then we want to take cine clips to show if stomach contents are moving through. Now, when you get a patient on your table and everything looks normal, pylorus is wide open, it's measuring less than 3 millimeters, measuring less than 14 millimeters in length, the other big thing to show is that those stomach contents are flowing through the pylorus. So quite often you just kind of keep taking cine clips. As you are watching the pylorus, you'll see it kind of start to bulge open, and then all of a sudden a bunch of the contents for the stomach will kind of whoosh through. And if you can catch that whoosh, that's an automatic, you've ruled it out, pyloric stenosis is not an issue because those stomach contents are moving through. However, though, sometimes babies don't have anything in their stomachs. So if the stomach contents are not moving, or if they don't have anything within their stomach, then you want to feed the child. And when I worked in the hospital, we fed them Pedialyte. So it's just like a clear, non-flavored water that a little bit is okay for infants to have. We had the parents feed the baby for us as we watched for the stomach contents to move through. Otherwise, some parents would prefer, and it also works, to use breast milk or formula to feed the baby as well. So as the baby is drinking, again, you want to make sure that you're watching the pylorus, watching for the stomach contents to move through. If they're not moving through and you have enlarged muscle, elongated canal, you've got a positive pyloric stenosis. So if the patient is positive pyloric stenosis, it is a surgical correction. It's corrected by a pyloromyotomy. So it's just this little incision on the abdominal wall. They go in and basically cut open the thickened pyloric muscle, and that allows it kind of to relax and expand and allows the pylorus to function as it should again. So we're going to watch a video here of the pylorus that is thickened in this patient. The baby has eaten, and we are not going to see anything moving through. So this is the stomach on the medial side, very thick, no contents moving through. Let's just watch that one more time. Very thick muscles, elongated canal. We can see that no stomach contents are traveling through. If you are inexperienced at doing pyloric stenosis, it is very possible that you might mistake the esophageal junction for the pylorus. However, you need to double check where you are. We know that the esophageal junction sits anterior to the aorta, and it sits right at the superior portion of the liver, right next to the diaphragm. So we are nowhere near the gallbladder in this view. You should be able to recognize where that gallbladder is. The pylorus should be right in that area. But you can kind of tell there's like kind of a canal looking area in long. When you turn transverse on it, you do get a little bit of that target shape, but that is not the correct area. Again, we can see here we have the aorta posterior. So we want to make sure that we're over a little bit more, looking more near the gallbladder. And then this video again will review some of the normal versus abnormal views on the pyloric canal.
Hello everyone and welcome back. Today I wanted to review the ultrasound appearance of pyloric stenosis. Here you're looking at the pylorus and you're going to see three different measurements. The two on the top are actually measuring the muscle in the wall, and that should be less than 3 millimeters. You can see here we got measurements of 0.2 and 0.18 centimeters, which is consistent with a normal pylorus. You can see that what we measure is actually the small hypoechoic area. Some people tend to measure the submucosa, the echogenic area, and that's not the correct measurement. It should be the hypoechoic area, which is the muscle. You also measure the canal, which should be less than 1.4 centimeters. In this case, we got 1.1. And this is a nice example of a normal pyloric canal. And this is a live image at CNET where you can see the contents, gastric contents, going from here and emptying through the pyloric canal. The reason I wanted to show this case is that at an outside institution, this was called an abnormal pylorus, and the measurements were actually borderline, but they were not really measuring the right anatomical landmarks. So this is an example of a normal ultrasound in a patient that had suspected pyloric stenosis, but it was in fact normal.
So I really like that one. We were able to see then how it looks when the stomach contents empty through. You can kind of see it kind of bunching up, and then you'd see kind of that whoosh of material traveling through. So if you're asked to do a pyloric stenosis, again, absolutely, you can always look with the ultrasound. Your confidence comes with the more that you see of them. But also be honest with your radiologist, be honest with the ER doctors. If you're not comfortable looking for them or are afraid that you're going to get kind of unequivocal information for them, then most places will have a children's hospital nearby. If they highly suspect it, they're going to get them to the right space. If a patient comes in with that vomiting and failure to thrive and abdominal distension, all of that, and they first think pyloric stenosis, and you get in there and you don't see a pyloric stenosis, you can prove that the pylorus is just fine. Another thing that we need to evaluate then is for midgut malrotation. Now, when the fetus is developing in the womb, the gut kind of originally starts out as this long tube. And then it kind of starts to twist a little bit, and then it twists back another way. And that's where we get kind of these folds of the intestine and all the little offshoots that we get, like the biliary tree and the pancreatic ducts. All those come off of this tube when the fetus is developing. So we expect that the tube will rotate in a particular way and it'll land in its permanent correct position. However, with midgut malrotation, the gut fails to rotate into its proper place, and therefore we get kind of this swirling, twisting in the wrong direction, kind of setting up the internal organs in a different way. So if we have that patient that has been vomiting, their pyloric stenosis test is negative, it's really quick to look for midgut malrotation if you know how to do it. So the whirlpool sign is associated with the ultrasound appearance of midgut malrotation. It happens because the superior mesenteric vein and the mesentery kind of twist in the wrong direction, and it kind of swirls everything, causing that whirlpool sign. On ultrasound, we'll also be able to identify that the SMV and the SMA are abnormally located to one another. And then lastly, we'll probably see some fluid in the proximal duodenum. Where this twisting occurs is just beyond the C-loop of the duodenum. And so at this point, we already have the stomach contents in there, and we have bile and pancreatic juices coming in. However, they can only get as far as where that twisting is. So now when the child vomits, they're going to vomit that bilious pancreatic chyme that came from the stomach. That's why it varies from pyloric stenosis. The stomach contents never make it to the duodenum to mix with bile and pancreatic enzymes. So pyloric stenosis is non-bilious, where midgut malrotation is bilious vomiting. Let's take a quick look then at what the normal relationship of the SMV and SMA are to one another. In the normal patient, we have the aorta, which sits a little bit more to the left of the body. SMA travels right above it. So we do see the SMA more towards the patient's left. And I want to remind you, these pictures are anatomically, not ultrasound. This is anatomical. So SMA and aorta hang out more to the left. and to the patient's right, we should see the SMV. So this is normal setup. In midgut malrotation, what we see then is the SMV is now more to the left, and the SMA sits more to the patient's right. We can also see where the SMV sits more anterior to the SMA. That is also an abnormal location. So on ultrasound here, we have an example. This is the aorta, this is the SMA, and the SMV. You're going to need to use color to evaluate this area. We're right inferior to the pancreas. We are using color and pulse wave to evaluate what are the vessels that are coming through here. We know that we should be able to follow the SMV up to the portal system, and we can follow the SMA connecting back to the aorta. And again, this is showing that they are abnormally located to one another. SMV should be on the right, SMA on the left. In this case, we have the SMA on the right, SMV on the left. Here's an example of the midgut malrotation showing that whirlpool sign. The mesentery and the SMV are kind of creating this swirl or kind of loop-de-loop in the mid-abdomen. Another gastrointestinal pathology that we come across quite often is something called intussusception. And intussusception occurs when a segment of bowel telescopes into another segment of bowel. We most commonly see these in the right lower quadrant or in the right upper quadrant. And the type that we most frequently see is the ileocolic intussusception. Now, we've talked about the ileum and the cecum before. We know that the ileum is the last part of the small intestine. Cecum is the first part of the colon or the large intestine. And what most commonly occurs with intussusception is that ileum kind of gets sucked into the large intestine. So it telescopes in, invaginates in, folds in, multiple ways to describe that bowel kind of scoops in to the next set of bowel. And that can happen anywhere along the gastrointestinal tract. It can happen in the small intestine. It can happen in other places in the large intestine. Anytime the intestine kind of folds onto itself, kind of sucks itself up into itself, that can occur. The most common spots that we're going to see, though, are at that ileocecal area in the right lower quadrant, or we'll see it up on the right upper quadrant near the liver. This is also typically a younger patient issue. So if a patient who is 50 comes in and they're looking for intussusception, it's a thing that can happen, but those patients usually have to have some sort of lead point, something that catches the intestine and causes it to do this. So that might be a lymph node or like Meckel's diverticulum. In children, though, it can just happen on its own, or they can also have these lead points. One thing that I saw working in the children's hospital, it was not uncommon for intussusception to follow a child who just had like the GI bug, where they were vomiting. So like they get sick with a GI bug, a couple weeks later, they're in with intussusception. And again, that's because those lymph nodes are enlarged in the abdomen, gets caught up on the bowel, causes it to fold over itself. Some signs that go along with intussusception then are going to be bilious vomiting and possible abdominal distension. So here's an example of what it would look like when that bowel folds into itself. So remember, we have the ileum here. The cecum is where it kind of connects to, moving into the colon. So in this one, the ileum is kind of been sucked into the colon, folding into the bowel itself. On ultrasound, there is something called a pseudo-kidney appearance or a donut appearance. And when you see some pictures, you'll see why. But in transverse, intussusception looks a lot like a transverse kidney. And then when you turn long on it, it actually kind of resembles a longitudinal kidney. So if you see what kind of looks like a funky kidney somewhere along the GI tract, that might be intussusception. You'll also note that the diameter of the walls of the bowel is a little bit thickened, up to 3 centimeters. The patients are also going to have what we call bloody jelly stools. You've also heard it referred to red currant jelly stools. So it's kind of bloody, very mucousy in appearance. And we should actually be able to see the invagination of the bowel onto itself with ultrasound. So here's an example of the pseudo-kidney appearance. Whenever I am scanning for intussusception, I make sure that I do show where the actual right kidney is. We can kind of see in transverse, this slightly resembles a kidney, and so we call it the pseudo-kidney sign. And this is up in that right upper quadrant intussusception. Here is intussusception in the longitudinal plane. We can see the outer layer of the bowel with the internal layer of the bowel sucked in upon it. This video is going to show us then the layers of the bowel within one another, and you'll kind of see how it also looks like a kidney in the longitudinal plane. So we can see layer of the first bowel, and then we have the layers of the second part of the bowel that's sucked up within it. And so you can kind of see too how this can kind of represent the same shape of a kidney with that echogenic center. I have another video here showing the same thing with layers of bowel within one another. So this is the outer layer, and then we have that internal layer. So when we start with the Intussusception Protocol, we want to make sure that we're starting where it's most common, so down in the right lower quadrant. You'll typically hold your transducer in transverse, sweeping up along the right side of the body, sliding across the transverse colon, and then sweeping down again through the descending colon. So up the ascending colon, across the transverse colon, and then down the descending. So we want to make sure that we are following the colon all the way around, looking for that invagination, looking for that pseudo-kidney sign. We also want to make sure that we're using enough pressure through the area to move any gas that might be in the way, move any small bowel that might be in the way, to really evaluate how the colon appears. These are also pretty hard to miss. Once you've seen one, you know exactly what you are looking for. And quite often, if it is present, you will be able to see it. If it is not present, all you're going to see is a bunch of gas in the baby's abdomen. So sometimes you just take representative pictures showing each quadrant in both transverse and longitudinal that you did not recognize any intussusception by ultrasound. Our next pathology then is called a Bezoar. And Bezoars are collections of foreign material that are in the stomach and can extend anywhere into the small intestine, which can cause an obstruction. Bezoars are typically named for the type of foreign material that they're made of. So we can have ones like Trichobezoar, which is hair balls, basically. We can have Phytobezoars, which are big balls of plant material. And you can have Lactobezoars, which occur most commonly in kiddos, especially ones that are being fed powdered milk. When we are looking for a Bezoar, it is not necessarily something that's going to be easily seen by ultrasound, but maybe you've got an ultrasound for a pyloric stenosis study or malrotation or intussusception, and you're looking through, you might see something that slightly resembles what we would expect a Bezoar to look like by ultrasound. But you will never typically get an ultrasound ordered to look for a Bezoar, as they are better visualized either through barium studies, abdominal x-rays, or with an actual camera with endoscopy. So basically what we can do with ultrasound is just kind of take a look through the gastrointestinal tract, seeing if we can find any complex mass or echogenic material within the area. Typically they're going to have a very strong echogenic band along the top, and then it'll be kind of just nothing but shadow behind it. So here's an example of a Bezoar. Again, we can see pretty good margins here. We can see that kind of anterior surface of the Bezoar and then just shadow behind it. we are not going to be able to definitively diagnose Bezoars based on ultrasound. Another structure that we can see via ultrasound is something called a duplication cyst. Now, duplication cysts, remember, when we're when we're developing as an embryo, we start out as a big tube, and then the stomach is kind of this outpouching of that tube, and that becomes the stomach, and then the tube does other things and becomes intestines, becomes the bile ducts, becomes the gallbladder, all of this. So all of these things are changing off of this tube. Well, sometimes there can be a duplication. And these duplication cysts appear when there's basically a second outpouching that is made of the stomach cells. So this area doesn't actually do much. It does have the same mucosal linings like the stomach does, and it typically sits right within the small curve of the stomach. But you can see in our picture here, we have fluid-filled area with multiple walls, kind of representing those walls that we see along the gastrointestinal tract. Another pathology that commonly kind of mimics the symptoms of appendicitis is something called mesenteric lymphadenitis. And this is going to just be inflammation of the lymph nodes within the mesentery, or within the abdomen. These can be enlarged due to infection, or it can be enlarged due to some sort of neoplastic malignant process. To diagnose mesenteric lymphadenitis, you need to see at least 3 lymph nodes that are enlarged. And for children, that does mean lymph nodes that measure more than 5 millimeters in the AP diameter. And lastly, another gastrointestinal pathology that we can kind of evaluate with ultrasound is something called necrotizing enterocolitis, or NEC, N-E-C. And with NEC, basically what happens is that blood to the bowel somehow gets obstructed or interrupted, and that causes ischemia. The bowel then starts to die, and this is very common in premature babies. As that bowel starts to die, it's going to progressively extend through all the walls, and when that happens, the walls can break open, air gets in there, and it is usually not accompanied by a good outcome. Necrotizing enterocolitis is very worrisome when we see it on these premature babies. We did mention it as a cause for portal venous gas in our hepatic lecture, but we can see that there are thickened bowel loops, some filled with fluid, and if we were to look up at the liver, we might be able to see some of that portal venous gas as well. And that brings us to the end of gastrointestinal pathology in the pediatric population. Up next, we're going to talk about urinary pathology in pediatrics.